Acute bronchitis is on page 583. It's the irritation and inflammation of the bronchi. It's usually viral in origin, and it is one of the most common complications of influenza, which is a virus. The other one being bacterial pneumonia. So it typically follows viral infections such as flu or even the common cold. It can be bacterial in origin, however, like the group A beta strep can cause acute bronchitis as well. Heavy smoking, allergies to dust, pollen, or other common causes of acute bronchitis. This slide is mainly just a repetition of what I just said, but it is important to distinguish acute bronchitis from chronic bronchitis. We're going to talk about chronic bronchitis when we talk about the patient with COPD. So acute bronchitis usually lasts 10 days or less. However, even after the bronchitis is relieved, the coughing can continue for quite. Symptoms of bronchitis include a cough, and it's usually a productive cough, which means it has mucus with it. The mucus might be yellow or green, indicating dead white blood cells. Fever and chills and chest discomfort. Here's a nice picture depicting the two things that occur with bronchitis. First, we have swelling and inflammation of the airway, so it becomes narrowed, and that's complicated by having increased mucus. So we already have a narrowed airway, and it's being clogged up with excess mucus. So it's a two-part deal. Treatment consists of maybe using a broad-spectrum antibiotic agent like ampicillin or tetracycline for 7 to 10 days. Usually, hospitalization is unnecessary. As nurses, we need to stress the importance of completing antibiotic therapy. Even when the person is asymptomatic, they need to continue taking the antibiotics until they're all gone. Encourage fluids, 2 to 3 liters daily, plenty of rest. They might use an expectorant, which we'll be talking about expectorants in pharmacology. Mucinex is one of those, which is guaifenesin is the generic name. I don't know if you can see that. It's real small right there. A humidifier, again, to moisturize the air. Tylenol to treat the fever, and a soft diet. The whole chicken soup thing, there's really something to that. Influenza is an acute viral respiratory infection. As you probably already know, it's highly contagious, and it's spread by airborne droplets, same as the cold. And in fact, most of what I'm going to say about the flu will be regarding how we distinguish it from the common cold. There are several strains of the influenza virus, A, B, C, and the strains are further subtyped according to the place and the year it was isolated, which is partly why people have to get a flu shot yearly or annually. Signs and symptoms. The incubation period is brief, 1 to 3 days, and then the onset is quite sudden. People will feel fine one moment, and the next they feel terrible. Headache, fever, and chills. And this is a big differentiation between flu and cold. With flu, fever is usually high and accompanied by chills, whereas with a common cold, often afebrile, or if there is a fever, it's low grade. Malaise, so not wanting to do anything, very tired. Myalgia, which just means muscle pain. Cough, sore throat. And the most common complication of the flu is pneumonia, both viral and bacterial. Diagnosis is made by the symptoms. Like I said, especially if someone has a high fever, that's a pretty good sign that this is flu and not just a cold, but also the nasal swab. There's a rapid influenza diagnostic test that takes less than 30 minutes. But a culture can also be done, but it can take a lot longer than that. Medical treatment for cold and flu are quite similar. Rest, fluids, proper diet. Let me get to that slide. Okay, rest, fluids, proper diet, antipyretics, that just means anti-fever, such as Tylenol, sorry about that, and analgesic drugs, also Tylenol is an analgesic, and chloroseptic lozenges can sometimes ease the pain, If antivirals such as Tamiflu are used, they need to be started 24 to 48 hours after the onset of symptoms, and they're continued for 10 days, kind of like an antibiotic. First generation antivirals are for type A flu only, and that is amantadine. The second generation, or Tamiflu, is for type A and B. The best treatment is prevention. I'm going the wrong way. So getting vaccinated, an annual influenza vaccine is recommended. I don't think this is available this year, but there is a live vaccine, flu mist, that's given intranasally to healthy children and adults. I'm not a big fan of this. I've never had it, but I don't like it because it's live. I don't want any live flu being put in me. The inactivated vaccine is the injection, and it's recommended, and that's what you normally get. And if I'm getting a flu vaccine, I want it to be inactivated. So again, flu shots are inactivated. A lot of people say they got the flu shot and it caused them to have the flu, and there's just no possible way that can happen. Now, can somebody get the flu after they have a flu shot? Yes, they can. And so there might be a correlation, but there's no causation. So this does not cause the flu, but maybe while they were waiting to get their flu shot, they were in a crowded, germy doctor's office and exposed themselves to the flu virus. So there might be some correlation, but this should not ever cause somebody to have the flu because it's an inactive virus and they just can't do that. You might have this accompanied by very mild flu-like symptoms for the first 24 to 48 hours after receiving the vaccine. Again, here's your side-by-side comparison of the cold and flu, and what we really look at here is the fever. With a cold, it's very rare. Also, when a patient reports having the flu, make sure you ask them about their symptoms, because for some reason, especially in our older people, people call a stomach virus the flu in this area. So sometimes when they say, I've had the flu, and you ask them, well, what happened? Oh, I had vomiting and diarrhea for 3 days. And so they're not talking about influenza, they're talking about a stomach virus. So just make sure you clarify that. Here's a sample question that I pulled from your study guide. For a client with influenza, which type of drug must be started within 24 to 48 hours after onset of symptoms and continued for 10 days? Hopefully you don't say antibiotic because, well, that wasn't a choice. Antivirals, such as Tamiflu. Pneumonia, again, is one of the complications of influenza. However, it can also be caused by infectious or non-infectious agents. Infectious agents other than influenza, which is viral, would be bacteria or fungi. So we can have bacterial, fungal, or viral pneumonia. Non-infectious agents may include irritating fumes, dust, or chemicals that are inhaled, or foreign matter that is aspirated. So your patients that are receiving tube feeding, we have to be careful that they don't aspirate their tube feeding. Nosocomial pneumonia is healthcare associated infection that may be attributed to inadequate hand washing, poor sterile technique with suctioning, or contaminated equipment, and exposure to others that have respiratory conditions. People who are most likely to contract pneumonia are smokers, those with altered consciousness, and of course those would be at risk for aspiration pneumonia. And altered consciousness might be caused from someone who uses alcohol or has seizures under anesthesia or drug overdose, or also those who are immunocompromised, chronically ill, malnourished, debilitated, or with prolonged immobility. So all of those people are at higher risk. Patients that are at increased risk for aspiration pneumonia, this right here, of course, are your patients that are have impaired swallowing or an impaired cough or gag reflex, those receiving tube feeding, or those that have a trach or ET tubes. Basic definition of pneumonia is inflammation of the alveoli and the bronchioles. So here we have the bronchiole, and this is representing the alveoli. So both of these become inflamed and filled with fluid. So to see if you were paying attention, see if you can answer this question. Who is at risk for having aspiration pneumonia? Well, all of these patients are at greater risk for having pneumonia, but the one that's specific to aspiration pneumonia would be the patient that receives tube feeding. So let's look at signs and symptoms of pneumonia. Fever, chills, and sweats. So kind of like your influenza, chest pain, cough, and the cough is going to be productive, lots of sputum production. You might see what we call hemoptysis, which is what we call it when there's blood-tinged sputum, so someone coughing up blood. Dyspnea, which is shortness of breath. Headache, fatigue. Older adults may experience confusion, loss of appetite, and weakness, but they might not have the fever and cough as bad as some of the younger people do. People with bacterial pneumonia may experience an abrupt, almost explosive onset with severe shaking and chills, sharp stabbing pain that they might mistake for something else. And viral pneumonia is usually not quite as abrupt on the onset. People report more of a burning chest pain with the viral pneumonia and a continuous hacking or barking cough. Not as much sputum with the viral pneumonia as with the bacterial. Diagnosis is made by history and physical, again, the symptoms that the patient reports, as well as a culture of the sputum. We also use chest x-ray, and we already talked about that previously when we were talking about common interventions when we're dealing with the respiratory system, and a CBC, which will reveal if they have an elevated white count, which indicates infection. Treatment, again, we're going to increase fluids. We want our patients to have at least 3 liters of fluids a day. If they can't drink adequately, we might even have to give them IV fluids if they're hospitalized. Limited activity or possibly even bed rest. We might use an antipyretic, Tylenol, not alcohol, to treat the fever, or an analgesic. Again, Tylenol does both. Antibiotic if it's bacterial. If not, we certainly wouldn't want to use an antibiotic for viral pneumonia. Oxygen may be required by some patients. Humidify the air, make it moist. If you're using a nasal cannula, you might want to put humidity on there. Bronchodilators, which I don't have pictured here, but those are sometimes helpful, or antitussives and expectorants. Antitussives and expectorants are kind of opposites. An antitussive just means anti-cough, so something like cough syrup with codeine or Tessalon pearls. When you have that barking, hacking cough that's not really coughing up anything, we might use antitussives, so for viral. Whereas if someone has bacterial, we might use an expectorant like Mucinex to help them thin the secretion so that they can cough it up. So it just depends on the symptoms as to what treatment we'll use. Back to diagnosis. If we are helping to obtain a sputum specimen, it's very important that we do things in the right order. So let's look at this sample question. A client with pneumonia is admitted to the hospital and the provider writes prescriptions. Which prescription should the nurse complete first? So all 4 of these are things that we're going to do, but we need to know which one we do first. Increase the intake of oral fluids, obtain a culture and sensitivity of sputum, administered antibiotics, or encourage the use of an incentive spirometer. Well, obviously, since I went to the sputum, this was the one. But it's important that we do this especially before we administer the prescribed antibiotics, because if we start the antibiotics and then collect the culture or collect the sputum, it will throw the culture off because they'll already have antibiotics in their system. So back to treatment. Of course, one of the best treatments is prevention. One of the prevention methods is preventing aspiration. And of course, we're talking about aspiration pneumonia here. So some of the things that we can do to prevent aspiration is have suction at the bedside, thicken a patient's liquids if they're having trouble swallowing, make sure the bed is elevated to 45 degrees during a peg feeding and for 30 minutes afterwards, peg meaning tube feeding. And if someone is receiving tube feeding, make sure that we put it on hold when we turn them or change diapers or something like that. And checking the residual. If the residual is greater than 100 milliliters, or if they're receiving a bolus greater than 20% of the hourly rate, we need to hold the tube feeding. And this is if there's not a more specific order. Occasionally a doctor will give you an order, hold tube feeding for residual, blah, blah, blah. But if not, this is a good rule of thumb, greater than 100. For other types of pneumonia, we recommend vaccination with the pneumococcal vaccine. The conjugated vaccine can be given to all children under 24 months and at-risk children up to 5 years old. Unconjugated vaccine is used for adults 65 and older and at-risk adults. Unconjugated vaccine is not to be